our senior and source of inspiration, Dr. Girish Mathur sir, with us. And before we move for the scientific program, I will request Dr. Girish Mathur sir to please say few words of blessing and inspiration to all of us.
Right side here.
Dr. Girish Mathur sir,
Thank you, Prakash ji.
please.
Good evening, friends. It's my profound pleasure to join today's program of case-based discussion in diabetes. I express my warm greetings and extend a warm welcome to all of you. I congratulate and compliment Chairman RSSDI Rajasthan Chapter, Dr. Prakash Keswani, for continuing this program this year also under his chairmanship. This program ran successfully last year, and Dr. Prakash Keswani was the man behind that program. And he deserves all credit of its success. I extend my very best wishes for a very successful tenure this year. I am sure we'll undertake many more innovative and useful academic activities this year during his tenure. I also extend my very warm greetings and felicitations to our dynamic secretary, Dr. G D Ramchandani. Today we have a very learned and illustrious panel who will discuss the case-based discussion today. I welcome Dr. Suchitra Yadav, Endocrinologist, Rajasthan Hospital, Jaipur. Dr. Puneet Saxena, Senior Professor in Medicine, SMS Medical College, Jaipur. Dr. Anil Samaria, Professor in Medicine, JLN Medical College, Ajmer. And our Dynamic Secretary and Endocrinologist, Diabetologist, Dr. G D Ramchandani. I extend my warm felicitation also to Dr. Arvind Gupta, past president. I can see him. Thank you so much. And my very best wishes for the success of the program. I'm sure we are going to witness a very enchanting and meaningful program this evening. Thank you so much, Prakash ji. I'm leaving because I have to catch a train.
Yes, sir. Thank you, sir. Thanks a lot for your kind words, sir. Everybody knows that this is because of the inspiration that we have started your program.
And today we are missing the presence of our father figure, Dr. K K Pareek,
yes, sir,
due to some unavoidable reasons. He could not join today. Otherwise, he was there on every program which we conducted last year.
Yes, sir. Yes,
we got his blessings for every program, and
yes,
we'll keep on receiving it. But today he is not able to join. Okay, Prakash ji, I'm leaving. Thank you so much.
Thank you. Thanks for your kind words.
Thank you so much.
Now, without wasting our time, we will move towards our scientific program. And as all the panel, the chairpersons, Dr. Puneet Saxena, Dr. Samaria, and Dr. G D Ramchandani has already joined, I will request Dr. Suchitra Yadav to start your presentation.
Good evening, my respected teachers, and thank you, sir, for giving me this opportunity. And I am starting my today's presentation. So, next slide. I am presenting a case of patient who is 37-year-old male who was the resident of Bharatpur, and he was a known case of type 2 diabetes and hypertension for last 10 years. And he was already on insulin, and he left the insulin for 3 days. And he presented in emergency department with polyuria, polydipsia, and dry mouth, and pain abdomen and vomiting and rapid breathing for 1 day. And the call came for emergency endocrine reference. So, revealing the 10 years history, he was a known case of diabetes for 10 years. At the age of 27 years, he suffered from balanitis. And for that, he visited a physician and he was diagnosed with diabetes. His initial blood glucose was 360 and his initial HbA1c was 13.6. At that time, patient had polyuria and polydipsia, but he did not have any history of weight loss. He was started on tablet glimepiride and metformin, 2 mg by 500 mg twice a day, and injection insulin glargine. Sir, am I audible? Am I audible, sir?
Yes, ma'am. You are audible.
Yes,
you are
sir.
audible.
Okay, sir. Okay, sir. Patient took this treatment for 2 months, but the fasting blood glucose remained high. His fasting used to remain in the range of 225 to 250, and his 2-hour PP used to remain in the range of 310 to 340 milligram per deciliter. Patient had history of headache for 7 to 8 years, which was holocranial, severe in intensity, throbbing type. It used to disturb the sleep of patient. There was some improvement on taking analgesics, and it was not associated with nausea, vomiting, photophobia, and phonophobia. Next slide. Patient also had history of enlargement of fingers and toes in form of increase in shoe size and tightening of rings. And there was also history of coarsening of facial features in form of protrusion of jaw, enlargement of nose and tongue, and widening of teeth. Patient had history of disturbed sleep, excessive daytime somnolence, excessive snoring, and unrefreshing sleep with frequent waking up. He also complained of tingling over the legs associated with pain. It used to get worse at night, and it used to disturb the sleep of patient. And there was no history of numbness or paresthesias over legs. And there was no history of slippage of footwear or cotton wool like sensation while walking barefoot. Next slide. Patient also had history of erectile dysfunction in form of, and he also had decrease in shaving frequency as well as decreased libido. And there was history of bilateral breast enlargement for last 7 years. He got married 7 years back, and he had no live issues. And there was primary infertility. And there was history of oily skin, excessive sweating over palms. There was no history of rapid weight gain, proximal muscle weakness, purple color stria, or history of intake of steroids. And there was no history of any visual field effects, floating the visual field, postural dizziness, loose stool, or constipation. There was no history of any joint pain or tingling sensation over hands. And there was no history of blood in stools.
Just a minute, Dr. Suchitra. So he was having diabetes for 10 years since the age of 27.
Yes, sir.
And at that time, he was only diagnosed with the diabetes and was started treatment with the oral tablets and one single time therapy. And these all features were seen nowadays after 10 years. Right? So at that time, there was no such problem.
Yes, sir.
And this time, stopping the medicine.
Sir, he noticed he had coarsening of facial features and headache, but that was insidious in onset and that gradually progressed. Patient did not give much attention to those symptoms, sir. And those symptoms were actually missed for last 7 to 8 years, sir.
Okay, right.
Yes, sir. He did not give much attention to those symptoms, and as they were gradually progressive, sir.
Okay, so he was having diabetes and gradually was developing these, there was increase of all these characteristics.
Yes, sir. Gradually progressive enlargement of hands and toes, fingers and toes, gradually progressive coarsening of facial features. It was so gradual that he did not notice. His far off relatives could not identify him when he met them after 8 years, sir. So that's why. And when we compared the photographs 8 years back, then we could realize that there is certainly difference between the facial
but was
features.
Not having good control of diabetes, so he was started with the basal bolus.
Yes, sir. He was started on basal bolus 2 years after the onset of diabetes, sir.
Okay. Anyone else?
But still,
would like to ask Dr. Puneet, Dr. G D Ramchandani, Dr. Arvind Bose. Okay, we can move forward.
Good evening, everybody. The only thing is that
your voice is we can't hear you, Dr. Puneet.
I think that the important Dr. Suchitra has told just now regarding the uncontrolled diabetes.
Yes.
Gradually uncontrolled diabetes in spite of the oral drugs and the insulin, basal insulin, and then ultimately they have to start the basal bolus.
Yes.
Yes, sir. Can I go?
Yes, you can move.
Sir, he remained compliant.
Yeah, let's continue, sir.
He remained compliant with his medications and he followed dietary restrictions as well. His blood glucose remained uncontrolled and he had to finally start on basal bolus regimen. And he was started initially on injection insulin aspart 12 units before breakfast, 14 units before lunch, and 14 units before dinner, and injection insulin glargine 28 units at bedtime. And even after starting basal bolus, his blood glucose remained uncontrolled. His fasting was in range of 250 to 300 and postprandial in the range of 300 to 350. Next slide. Insulin dose was gradually increased to 125 units per day. But blood glucose levels remained uncontrolled, and he never developed hypoglycemia even after receiving 125 units per day. And for the last 2 years, he was taking regular insulin 30, and 25 pre-meals, and injection insulin glargine 40 units at bedtime. And there was no history of swelling over feet, periorbital puffiness, nausea, or frothy urine. No history of typical or atypical chest pain. No history suggestive of stroke or intermittent claudication. And there was no history of any foot ulceration during this 10 years, sir. Patient was taking insulin regular over the abdomen and lentus over thigh region, and he was properly following the rotation technique, and he used to change his needle every third day for glargine and every day for regular insulin, and he used to keep the insulin in refrigerator shelf and used to carry insulin over ice pack. He was following everything, sir. He was following his diet, he was taking it properly, he was storing it properly, and in spite of that, he had uncontrolled hyperglycemia. There was no lipoatrophy or hypertrophy over the insulin site. And during these 10 years, during these 8 years, he got exposed to glargine U100, U300, regular insulin, and analogs. And there was no family history of diabetes in first and second degree relatives. Sir, can I continue? Can I continue, sir?
Yes, yes.
Yes, sir. And drug history, he was on injection insulin, human act rapid 30 units before breakfast, 30 units before lunch, and 25 units before dinner. And injection glargine 40 units at bedtime. And for hypertension, he was taking telmisartan and hydrochlorothiazide and tablet amlodipine, sir. Next slide. So to summarize my history, he was a 37-year-old male who was a known case of diabetes and hypertension for 10 years with poorly controlled diabetes, with headache, acral enlargement, coarsening of facial features, with history suggestive of DKA, with diabetic neuropathy, hypogonadism, with no history suggestive of adrenal insufficiency, diabetic nephropathy, or diabetic retinopathy, sir. There was no history suggestive of diabetic retinopathies. Next slide.
Okay. Yes.
Sir, on examination in the emergency department, his blood pressure was 104/64 with no postural fall, and his pulse rate
before
was
for
high.
examination, can you summarize all these things? Patient has type 2 diabetes, uncontrolled,
Yes.
with good.
Yes, sir.
Please.
Yeah. Previous slide, please. Previous slide. Sir, he was a 37-year-old male who had diabetes and hypertension for last 10 years. And in spite of taking basal bolus and 125 units per day, he had poorly controlled diabetes. Along with that, he had gradually progressive, insidious in onset headache, acral enlargement, and coarsening of facial features in form of protrusion of jaw, enlargement of nose and tongue. And there was history of decay at the time when he presented in emergency department. He had pain, abdomen, vomiting, and breathlessness. And he had a history suggestive of bilaterally symmetrical, distal symmetrical polyneuropathy, diabetic neuropathy. And there was history suggestive of hypogonadism with no history suggestive of any adrenal insufficiency or diabetic nephropathy or diabetic retinopathy, sir.
Right.
Dr. Chita,
So,
was
Dr.
this headache
Dr. Suchitra,
this
Yes,
headache
sir.
force patient, whether this headache force patient to wake up in the morning?
So, headache was, sir, headache was of same intensity throughout the day, and it used to disturb the sleep of patient. Sorry, sir,
So,
I didn't
doctor,
get your question. Can you please?
Was this headache
question-
force patient to wake up in the morning?
when patient wakes up in the morning, it was very severe headache. Is it so?
Sir, it was of the same intensity. There was no diurnal variation, sir.
So, Dr. Suchitra, for the headache was persisting for a long time. So, did he consult or there was any treatment history for headache?
No, sir.
And
No, sir. He did not.
He must have had some investigations also for headache in that case.
Yeah, sir. He actually never consulted. He never gave much attention. He used to take analgesics from some private practitioner, from local chemist, and he used to take analgesics. There was some relief with the analgesics, and he never got investigated for the headache, sir.
But there were no symptoms suggestive of raised ICT or blurring of vision, that kind, right?
No, sir. There was no symptoms suggestive of any visual field defect or any raised ICT or any cranial nerve palsy, sir.
So this point is very important. That patient who are having headache, taking analgesics by the chemist, although he was having hypertension also, that might
Yes,
have
sir.
also disturbed. This is very wrong.
Yes, sir. Yes. Yes. Can I go ahead, sir?
Yes.
Yeah, please.
Okay, sir. On examination, sir, in the emergency department, his blood pressure was 104/64, and there was no postural fall in the blood pressure, and pulse was 106 beats per minute, and respiratory rate was 32 per minute. There was no pallor, edema, cyanosis, clubbing, icterus, or lymphadenopathy. And his height was 178 centimeter, which suggests the post-pubertal onset of the disease. And his weight was 92 kg, and his BMI was 29, which is grade 1 obesity, according to Indians. And his ankle brachial index was 1.31, which was measured later when he got stable. And his general examination revealed he had prominent supraorbital ridges. He had enlarged nose and tongue. He had protrusion of jaw and widening of teeth. And acanthosis nigricans was very significant. It was present over forehead as well. It was present on neck, axilla, and forehead is the unusual site for the acanthosis, but it was present in this patient. And there were multiple skin tags, and he had enlarged hands and feet, and his skin was oily and sweaty. In the presence of dehydration also, his palms were sweaty. And he had sparse facial hairs, sir, and beard and mustache were sparse, and he had sparse axillary and pubic hair as well. And his testicular volume was normal. It was 20 ml bilateral, and insulin injection site was also normal. There was no evidence of lipoatrophy or hypertrophy at the insulin injection site. Next slide. So this was the patient when he got stable, and it was the picture was captured when he got stable. And as we can see, there is protrusion of jaw, there is a bulbous nose, there is enlargement of lips, and prominent supraorbital ridge, and the acanthosis over forehead could not be seen here in this photograph. And there are sparse beard and mustache, sir, in a 37-year-old male. He himself said that the shaving frequency has decreased in last 8 to 10 years, sir. And we can see enlarged hands as well as feet, sir, in this patient. Next slide. So his higher mental function were normal, and cranial nerve examination was also normal. Although he did not have any history suggestive of retinopathy, but fundus examination revealed mild non-proliferative diabetic retinopathy, and there was no macular edema. And in motor system examination, tone was bilaterally normal, power was 5.5 at all the joints, and plantars were flexures bilateral, and deep tendon reflexes, ankle were absent in both the sides, and at knee it was 1+, and normal at upper limbs, sir. And sensory system examination, vibration was bilaterally absent till knee, and it was present at bilateral iliac crest, and pinprick sensations was reduced bilaterally, and fine touch, it was impaired up to knee, and temperature sensation was well preserved, and proprioception was impaired at great toe, and it was normal at ankles. There was no cerebellar signs. Next slide. And rest of the examination was normal, and There was no kyphosis, scoliosis, no dipterin contracture, and there was a tabletop sign was negative. Next slide. To summarize, he was a 37-year-old mildly obese male with 10 years history of type 2 diabetes and hypertension, presented with poor glycemic control on basal bolus, with complaints of polydipsia, tachypnea, nausea, and vomiting after omission of insulin for 3 days, with background history of headache, acral enlargement, and coarsening of facial features, with clinical examination suggestive of distal symmetric polyneuropathy, with mild right eye non-proliferative diabetic retinopathy without any nephropathy and macrovascular complications. So it was, the provisional diagnosis was active acromegaly, as the patient had uncontrolled hyperglycemia and oily skin and sweaty skin, and type 2 diabetes, secondary hypertension, DKA, with distal symmetric polyneuropathy and non-proliferative diabetic retinopathy. Next slide. So his plasma blood glucose were more than 600 milligram on glucometer, and urinary ketones were positive by dipstick, and venous blood gas analysis pH was 7.02 and BICA was 7.8, and patient was started on IV fluids and insulin infusion. His insulin requirement was 174 units in initial 24 hours, and his electrolytes, calcium profile, renal and liver function tests were normal, and hormonal workup revealed T4 3.5. It was total T4 and it was low. And TSH was 1.2, which was normal. 8M cortisol was slightly high, 592 nanomole per liter. And after suppression with 1 milligram dexamethasone, it was suppressible. So the cortisol might be due to stress which the patient was having at that time. And ACTH was 35 picogram per ml. Serum prolactin was 17.9 and testosterone was very low, 1.3 nanomole per liter, and IGF-1 was very high. It was 769 ng per ml, and growth hormone suppression test was done using glucon-D powder, and growth hormone following glucose suppression test was 120 ng per ml, which was very, very high. So in point of all this investigation, his MRI SALA was planned and it revealed a salar suprasellar mass, which was 4.8 into 3.2 into 3.5 centimeter, and it was abutting optic chiasma, sir. And visual field examination revealed bitemporal hemianopia, although in history he denied any visual field defect, but on visual field examination, bitemporal hemianopia was present, and 2D echo revealed left ventricular hypertrophy. Colonoscopy was done to rule out colonic polyps. It was normal. Next slide. Yes, sir.
Yes.
Yes, sir.
Yes, sir. Yes, continue.
Yes, sir. So the final diagnosis was active acromegaly due to macrosomatotroponema with secondary diabetes, secondary hypertension, DKA, secondary hypothyroidism, secondary hypogonadism, distal symmetric polyneuropathy, and mild non-proliferative diabetic retinopathy.
In a nutshell, it was a very good case with young onset diabetes.
Yes, sir.
Possibly because of the acromegaly or growth hormone
Yes,
excess, and producing all the complications
Yes,
of
sir.
diabetes and all the complications of pituitary tumor also. So what are the factors which causes excessive blood sugar levels and uncontrolled hyperglycemia more commonly in acromegalics? Why so?
Yes, sir. The main mechanism is, sir, GH. Yes, sir. Sir, GH actually it has antagonistic effect to insulin, sir, at all the levels, at liver, at skeletal muscle, at adipocytes. It antagonizes the action of insulin by interfering with post-receptor signaling. And sir, there is increased GH-mediated lipolysis also, although, sir, the main mechanism is insulin resistance. So the presentation with DK is very rare, as the insulin resistance is the main mechanism. But in presence of uncontrolled hyperglycemia, there is glucotoxicity as well as lipotoxicity, which leads to beta cell failure. And also there is GH-mediated increased lipolysis, which leads to increased ketone production. So that is the possible mechanism which leads to DKA in such patients. And for the diabetes, the main mechanism is insulin resistance at all the sites, sir, at the liver, at skeletal muscle, and as well as adipocytes.
Can this hypertension be because of this acromegaly or because of diabetes in time he has developed?
Yes, sir. There is the effect of GH on the renal tubules. It has, sir, anti-diuretic effect, sir. There is GH mediated increase in extracellular volume as well as GH mediated insulin resistance, which leads to increased sodium as well as water retention, which contributes to hypertension in this patient, sir.
Okay.
Yes. Can I go ahead, sir?
Yes. And for these, anything, Puneet, Dr. G D Ramchandani, will you like to ask? So, because of the diabetes, possibly acromegaly, he has developed diabetes, uncontrolled diabetes, and uncontrolled hypertension, and many of the other features. Does this growth hormone excess also have some additive effect for the development of the retinopathy?
Sir, growth hormone per se does not contribute to retinopathy, and there are not much studies on this, sir. But diabetes and hypertension, they are responsible. Mainly, they are responsible. And growth hormone might have permissive effect on the retinopathy, but only growth hormone causing retinopathy, sir, I think they are not
IGF
much.
has some role, and because we also give inhibitors of VEGF and all those.
Yes, sir. Yes, sir. Growth factors are responsible for. Yes, sir. IGF-1 has.
Something. So it was a really good case. Yes, we can go forward.
So he was diagnosed as acromegaly due to macrosomatotropinoma with secondary diabetes, diabetic ketoacidosis, secondary hypothyroidism and hypogonadism. He was started on levothyroxine and testosterone replacement, and he underwent transsphenoidal pituitary surgery uneventfully. He did not develop CSF rhinorrhea, but he had polyuria which resolved after 3 days. So though the polyuria was transient, the transient DI was there post-op, which resolved on itself after 3 days. And post-operatively, day 2 serum GH was done, which was 4 nanogram per ml, which was high, and cortisol was 450 nanomole per liter, which was normal. His insulin requirement gradually reduced to 50 units per day, and he was discharged on basal bolus regimen, 10 units subcutaneous TDS regular insulin, and 20 units Lantus at bedtime. And after 3 months, he was re-evaluated, and his blood glucose was fasting 120 to 140 milligram per deciliter, and 2-hour postprandial blood glucose was 150 to 160, sir. Next slide.
That's really good. After removing the tumor and load of the growth hormone secreting cells, blood sugar improves with lesser amount of the insulin.
Ji, sir. Ji. Serum IGF-1 after 3 months was 450 nanogram per ml, and growth hormone was 3 nanogram per ml following glucose suppression test, which was suggestive of residual functioning somatotropinoma. And his T4 was 7.4 and testosterone was 7 nanomole per liter on levothyroxine and testosterone replacement. And his ATM cortisol was 400 nanomole per liter. Sir, repeat MRI after 3 months showed a residual tumor of 1.2 into 1.1 into 0.8 centimeter. Although the load of tumor was decreased to almost 75%, 75% reduction in the mass was there, but he still had residual adenoma, and patient was planned for stereotactic radiosurgery, and he was planned on to start on injection HCG to achieve the fertility of the patient. As the testicular volume was good, there was no need for HMG. He was directly started on HCG for the fertility. And after 3 months, a patient was shifted to oral medication and basal insulin. He was shifted to tablet glimepiride plus metformin and injection insulin 18 units. And his blood glucose remained controlled on this treatment, sir. Next slide. Next slide.
We are not able to hear you, Suchitra.
Sir, I'm not able to see my slides, sir. What happened? I don't know.
Okay, so
Where is Ajay?
It is
Sir,
showing.
can I see my slides?
We can see it.
Okay.
It's your network problem, ma'am.
Okay. So, sir, it was the case is almost finished. It was a case.
Last slide is blood glucose remained well controlled. Fasting
Yes.
was 100 to 130. 2
Yes,
hours
sir.
50 was 150 to 160. So blood sugar levels are very good in the control range after debulking the tumor of the growth hormone producing cells, right?
Yes, sir.
And blood pressure was also 124/86 on
Yes, sir.
telmisartan plus hydrochlorothiazide. So
Yes,
what
sir.
was he initially was taking more number of the tablets for the hypertension?
Sir, he was initially on 3 drugs, sir, telmisartan plus hydrochlorothiazide and amlodipine as well. He was
Okay.
on 3 drugs, and post-op he was shifted on 2 drugs, sir, hydrochlorothiazide and telmisartan.
So we can say that after removing the tumor, sugar level as well as the blood pressure both improves.
Yes, sir. Both improved, sir.
The next
And-
line is patient underwent stereotactic surgery, and
Yes,
during
sir.
the period he was started on injection of octreotide.
Yes,
6
sir.
months after initiation of SCG, his testosterone values got normalized. Serum analysis revealed sperm count of 15 million per ml, and sperm's motility was 40%.
Yes, sir.
So what was your interpretation with this? That
Sir, actually, initially he had hypogonadism. His testosterone was low, so semen analysis was not done pre-operatively because it was expected that he will have azoospermia in presence of such low testosterone. Post-operatively, after starting HCG injection for 6 months, semen analysis was done, which got normal within 6 months of initiation of HCG injection, sir. And sir, the fertility was not yet achieved, but the patient is not in follow-up also.
for information to all, can you tell that why testosterone was low and T3, T4 was low in this patient?
Yes, sir. It is due to the mass effect of the tumor that the thyrotropes and the gonadotropes are suppressed due to the mass effect of somatotropinoma, which was there. And due to the mass effect, there is suppression of the thyrotropes and gonadotropes, which leads to decrease in LH and as well as FSH, and ultimately decreased testosterone also.
Okay.
When the mass effect was relieved, and LH HCG in form of HCG was given from outside, the testes were normal, which they could make sperms, and semen analysis got normal after initiation of LH in form of HCG.
Right. So with this, your case is over now.
Yes, sir.
Any other points you will like to highlight, Dr. Puneet, Dr. Ramchandani, Dr. Anil, Arvind Boss?
I think it's a wonderful case and presented nicely by Dr. Suchitra. Truly amazing. And the 2-3 things I would like to say in this case, that probably we are missing in early stage in such type of cases because there's no high index of suspicion because regarding the secondary diabetes and secondary hypertension. And secondly, why it is known as that is a master gland. Pituitary is known as a master gland. This is a classical example of that master gland and masterly presented by this case by Dr. Suchitra. That is affecting not only blood sugar, the hypertension and gonads, thyroid, every system, every thing were affected by that gland. And like second thing, how the things were reversed after doing the timely diagnosis and surgery. So this is truly very good case and very good presented by Dr. Suchitra. So truly amazing.
Thank you, sir.
Yeah, very good
Thank you,
presentation, Dr. Suchitra.
Yes, Dr.
I would like to comment something. I am Dr.
Yes, yes.
Girish Sharma.
Yes.
Thank you, sir.
So Suchitra, इसमें
Actually,
whenever we
the
have a
message-
One
case
by
of
one,
a
Dr.
young-
Puneet, you can continue. One by one, please.
हम इसको स्क्रीन हटा दें मैम अगर हो गया केस तो पूरा.
Sir, I had some few interesting slides related to the acromegaly, but I am not able to see that.
I just wanted to comment that whenever we are seeing young patients and
Can I comment something,
for suspicion of secondary diabetes.
Can I comment something? Can I comment something?
Just a minute. So whenever we are seeing young patients with diabetes, and especially those who are not controlled, we should always look for secondary diabetes. The incidence of secondary diabetes is higher as we see in clinical practice, just because we don't have a very high index of suspicion in the initial phase. And just like this patient who was acromegalic and kept on ignoring, and probably not only him, probably the treating doctor also kept on ignoring perhaps the enlargement of, and kept on increasing dose of insulin. So increasing weight and acral enlargements and all signs of acromegaly, including headache and everything, was there. So maybe he could have been diagnosed much earlier in that way. So keeping a very high, and especially if somebody is not responding to
Yes.
heavy doses of insulin, so that also should raise a suspicion of any other culprit, whether it's a hormonal problem or a drug or any other disease. Maybe a
इसी तो
infection
करके
caused
लाया
infection.
तू जा रहा है मेरे तो तू भी हाथ धो रहा
So it was a very nice case, and but most of us see these cases, and we also tend to miss them in very initial phase. So I also had a similar patient recently, and for 2-3 months the sugar was not controlled, but later on came to know that probably she is getting acromegalic, and almost the case proceeded like what you have presented today. So very good case presentation overall.
Thank you, sir. Thank you, sir.
Very rightly pointed out, Dr. Puneet. We have always to keep our eyes open, and we should suspect these patients for having some other endocrine or other secondary cause for diabetes.
Sir, can I ask one question?
Yeah.
Yes, sir. Yes, Dr. B.K. Gupta, sir.
Can I first comment
Dr. B.K.
something?
Gupta.
Can I first comment something?
Sure,
Yes,
sir.
sir.
Sure.
Okay, should I speak?
The only thing which I wanted to point out is that day by day we are forgetting our skills.
Yes.
A good observation, good history could have been taken by observing that the blood sugar is not being controlled. As she has taken very nice history, I must compliment the presenter, Dr. Suchitra, very nicely presented and very clearly elaborated. So,
Thank you, sir. Thank you, sir.
very nice. And if we are forgetting this skill of, because of, I mean, the burden which we are getting, so we have to give sufficient time to the patient to know about the history. If we are not getting the right parameters, so we should think over it and try to give some time for history as well as clinical examination. Because if patient has prognatism, as you said, protruded jaw, so that could have been observed by the physician himself, provided the only physician to whom he was coming again and again.
Yes.
And changes over the face, changes in the ring size, if he mentions it, changes in the shoe size, and even if patient wears the cap, change in the cap size and change in the facial features. So all this could have been taken into account, and I think it could have been picked up a bit earlier, but certainly sometimes maybe missed. But the forgotten skill we have to revive, whether it is history or physical examination. Thank you very much.
Definitely, sir. Very good points you have mentioned. We have to always go for the clinical medicine first. We should give more time for observation and examination.
Yeah, very nicely said, sir.
Okay, should I speak, Dr. Prakash?
Yes, Dr. B.K. Gupta, sir.
Okay. It was very nice presentation by Dr. Suchitra. Although some findings they remain unexplained, like despite Ixol and despite hypothyroid state, patient was having tachycardia. Why patient was having pulse rate 100 more than?
Yeah, sir. When he presented in emergency department, he had DK, sir. At that time, he was dehydrated, and that's why he had tachycardia, sir. At that time, and although even in presence of dehydration, he had sweaty hands. That was the clue that he has DH excess. Even in presence of dehydration, his hands were sweaty, sir.
One question can I ask?
Yes.
Yes,
Why the Dr. Neeraj? Yes, sir. Why the cortisol level is not decreased? Both this testosterone, this gonadotropes and other
yes, sir.
thyrotropes
Sir,
are
actually,
affected. because of compressive effect, it should have also, or any
Yes, sir.
reason for that?
Sir, like it is a life-saving skill the body has. The corticotropes are last to go. In any case, sir, even in any pituitary tumors, the corticotropes are last to go. The earliest to be affected are the other cells, and it is probably a defense mechanism by the body. They are well preserved till the end. And this patient had high cortisol level initially due to the stress which he had, the hospitalization stress, the decay stress. But it was suppressible on tablet dexamethasone. On giving tablet dexamethasone, it was suppressible. And even in case of radiotherapy and in case of tumor, corticotropes are last to go, sir. They are well preserved till the end.
Dr. BK, the cortisols and the glucocorticoids are the most important hormones they are for the body. And this is a protective mechanism of the body, and the place of the corticotropes in the pituitary helps them to survive for a longer time as compared to the other hormonal cells. Anyone else?
Nice presentation, sir.
Yes,
Dr.
Dr.
Suchitra,
Samaria,
congratulate.
yes.
Very nice presentation over the acromegaly. We always miss the secondary diabetes.
Yes,
Definitely.
many times.
Dr. Girish Verma said very nicely. We have to watch carefully, listen carefully to the patient. So we make a diagnosis on the table side, because this boy has a large protruded jaw. There is a continuously headache, secondary diabetes, not responding to insulin. That said by the Dr. Puneet Saxena, sir. It is our job to listen carefully, examine thoroughly the patient, so we can make a diagnosis in 80% of cases. Dr. Suchitra, very nice presentation. And acromegaly, cortisol level will always present in the delayed, especially in somatotropin tumor, because its tumor involve the microadenomas. So there is not necessary to involve the cortisol also. So treatment part is very good. The treatment choice is surgery. Transfusional surgery is the better choice. Opioid depots are available nowadays. Growth or dopamine receptor agonists are also play a role in these conditions. So Chitra, I congratulate one against. Dr. Prakash Keswani sir very nicely handled the case. Thank you very much.
It was a really a nice case.
I want to comment, sir, one thing.
Yes.
Yeah. The take-home message, I can say.
Yes.
The medical field is a lifelong learning.
Yes.
And recognizing that making common mistakes is a part of the learning process. So probably we all are learning, still we are learning. Continuous improvement through reflection on errors is essential for providing better and safer patient care. Learning from mistakes involves reflection, acknowledging the error, understanding the root cause, and developing strategies to avoid repeating it. Indeed, accepting mistakes is a vital aspect of professional growth in the medical field. So we are learning every day to day by our own mistakes. So
every time.
Yeah, till death we are the learner.
And congratulations, Dr. Prakash. Congratulations for continuing this phenomena.
That is
this is all inspiration because of you, senior sir.
This is really good that we are also learning out of that.
No, sir, this is all because of the inspiration by seniors. And seniors like you who have been principals of the medical college and have taught us, and still you are joining to support us, to inspire us. We are really happy.
I'm still eager to learn from Dr. Prakash, who is a learned fellow.
He is the master. He is the master gland of the RSSDI, and this case discussion is I think is the master endocrine gland.
No. We all are brothers, and we will learn by ourselves, by each other.
Of course.
Excellent. Truly.
Very good. Thank you, Dr. Suchitra, for nice presentation, good case selection, and nice.
Thank you, sir.
All the things. And all the panelists, Dr. Ramchandani, Dr. Puneet, Dr. Samaria, and more than that, Dr. Girish Verma sir, who all participated, Dr. BK Gupta sir, and it was really a good case discussion and learning for all of us. Thank you all.
Thank you very much.
Good night, sir.
We will meet on the second Thursday of the next month.
Okay.
Bye,
Thank you very much.
Thank you, sir, for giving me the opportunity.